there's that. So let's go back to that because I just did this. So stop sharing that. So what I'm going to do, all right, let's try this again. Share the screen. Pull this up. Are we doing, do we have it? Do we have it?
Yeah, it looks like, well, it's like
Oh.
showing half of it.
Half of it?
Yeah.
Great. All right, let's try this again. How many of you will love to be done with Big Blue Button? Yeah, me too. All right. You know what? I may do one other thing. Let me try this other thing. Upload a presentation. If I were to drag this into here, is that going to work? No, it's not. Okay, that's not going to work. So go back. Now we're going to do this again. We are going to make this work. Here's the screen. How are we doing?
It's still only showing like half of the presentation. Do you just want me to present and everybody else can just follow from Canvas?
Yeah, that would probably be the wisest. Let me just.
Kind of showing the whole thing now. It doesn't look like it's on present mode, but like the whole.
Okay, it won't be on present mode. Just give me so. Just want to see what I wish I could see what you guys are seeing. That's just it because it takes up my whole screen. So let's get back to from beginning. Okay. So do you see movement now? Do you see the diabetes with the little cat there?
It's still like half the screen, but yeah, we can see it.
Okay, yes, people, just pull up your Canvas and pull up the PowerPoint and we'll just follow along. How's that? I don't understand why that's doing half the screen. I don't get it. Okay, go ahead.
All right, so my presentation is on lifestyle changes with diabetes. And I don't know if you guys have seen the little video, but that cat says diabetes the Southern way, the way that Carolyn said it. So I thought that was cute. You can go to the next slide. So a little bit of history on diabetes. My thing doesn't work. So the first documentation of it was by an Egyptian physician. He documented frequent urination and emaciation with a mysterious disease. Ancient healers noted that ants were attracted to the urine of the people that had this mysterious disease, And then a Greek physician described what we now call diabetes as the melting down of flesh and limbs into urine. The way that they checked and diagnosed people with diabetes is they had people called water testers, and they would taste the urine of people that they thought had it. You can go to the next slide. Okay, there's some bad pictures, but I didn't find a before picture, but right before I had diabetic ketoacidosis, these are pictures that I took. It was my sophomore year's school picture. I don't normally look that gross, I hope, but yeah, you could tell I look pretty pale and I was pretty skinny. So yeah, I didn't have I took the fasting blood glucose test and it came out fine. So they thought I wasn't diabetic, but a week later I wasn't doing hot. I went to the hospital and my blood sugar was 593. So they're like, congrats, you're diabetic. And yeah, downhill from then. Next slide.
Did you want to go over those lab values?
I mean, sure. So
diabetic. No, I didn't know. It's just part of your presentation.
Okay.
I just
kind of included it so people kind of know the different lab values, but I wasn't going to go over the specifics.
Okay.
So the causes for type 1 of diabetes is unknown. They know that it is autoimmune and there's damage to the beta cells. They think people that have it have this HLA gene more commonly. Next slide, please. So the risk factors for it often develops in childhood. I was a little bit older getting it. I was already 15 at the time. But, you can have LADA, so there's that too. People with a history of it in their family usually have it more often. I was the first in my family. Nobody else has it, so everybody thought I was bulimic or something because I lost 20 pounds in 2 weeks. Most people that are type 1 have noticed that get type 1 diabetes shortly after having a virus. So I do remember I went to the Dominican Republic that summer and I got sick while I was there. And then shortly after I started drinking a bunch of water, eating a bunch of food, going to the bathroom a lot, and all the symptoms. And then living in a colder climate shows that it's just higher risk factor for having it. Next slide, please. Okay, like Vicky said yesterday, type 1 diabetes is only the 5% of diabetics. It occurs in 10 to 20 or 10, 100, wow, I can't speak. I'm nervous even though you guys can't see me. Per 100,000 people in the United States. By age 18, approximately 1 in 300 people have developed type 1. It's more common in countries in Europe, the United Kingdom, Canada, New Zealand. It's much less frequent in Asian and South American countries. Next slide, please. So at the moment, there's 1.6 million Americans that have it. 64,000 people are diagnosed each year with it. And 5 million people in the US are expected to have it by 2050. Next slide, please. So they saw a surge in it between 2001 and 2009. I didn't see why they think that happened, but that was the case. There's currently $6 billion in type 1 diabetes associated healthcare. That was one of my main concerns when I was diagnosed, because I know I shouldn't care about it, but I saw how expensive everything was. Yeah, they give you the free meter, but the little strips are so expensive. Then you have the strips, the insulin, the needles, the alcohol swabs, the Lancets. So it's very expensive. And then if your insurance, if you bug your insurance to cover you, they'll you can get different methods. So I currently have a CGM and a pump, but those are expensive too. So it's a very expensive disease, unfortunately. So I put that little video of the dog with the cupcake because a lot of people have misconceptions with type 1 diabetes. Sometimes they kind of mix it in with type 2. So when I was first diagnosed, a girl told me oh, you're not that fat. What did you do? Eat too many cupcakes? I've had a lot of people tell me things that I thought were just kind of rude, and I don't think they realize that like it could come off as off-putting. I did have a friend say like decline eating candy in front of me, and she's like, "Well, I don't want to be diabetic like Victoria." So I'm a kind of a petty person about that. So having a family member that does increase your risk of having it, but many people don't have a close family member with it. I have a coworker that has diabetes, has it since she was 9, and her 3 kids don't have it. So it's not always like you're going to get it. Eating sugar does not cause you to have diabetes. It's autoimmune. Type 1 doesn't have a special diet. Like there's no recommendation. I remember asking at the hospital, like, what's my diet? Can I not eat French fries anymore? Like, what's my carb limit? But they're like, nah, just eat what you want. You just have to count the carbs. Yeah. Next slide. We can eat sweets. I always get a face when I'm eating a donut or something, but that is normal. We can eat whatever everybody else is eating. And sometimes we even need to eat sugars. When I am at like 46, I will be downing anything and everything that's in my sight. Exercise does help boost your body sensitivity to insulin and helps lower your A1C. So I didn't realize that I had a lot of these symptoms. The main 3 that you want to know for like the symptoms of onset are extreme thirst, frequent urination, and increased appetite. The other ones vary by person, but yeah, like I lost 20 pounds. My breath smelled fruity. My mouth was so dry, like my saliva was always white, and I just kept downing water. Next slide, please. So I'm putting these symptoms in because you always have to be aware of like what's going on with your body. Like either hearing me beeping in class and me looking at see what's going on. Before that, I had to be like more vigilant on my body. Like, oh, am I shaking right now? Or like, am I feeling weird? Am I like extra hungry? Am I like confused? Which is kind of hard to notice because it's a weird thing that happens to your body, but you have to be vigilant with that. So for hypoglycemia, the symptoms vary per person. I get really shaky and sweaty and then very hungry. You're supposed to eat 15 grams of carbohydrates that should be fast acting. So like apple juice, glucose tablets, some kind of candy. Wait 15 minutes. That's the hard part because when you feel like that, you just want to keep eating. And then you're supposed to check and repeat if it's still low. Next slide, please. And then for when you're high, those are some of the like symptoms that people have. It says to call your provider if you're high. I try, correcting it myself because I don't want to call my doctor every time I'm at 400, 500. If you get too high, you definitely need to, and you can't bring it down. You have to call your healthcare provider. But drinking water helps me lower my blood sugar. Like light exercise, like not gonna go run a marathon, but like go down some stairs, go for a walk. And then give myself a correction is basically what I do. Next slide, please. So those are some of the tests that they do for diabetes. I said like mine came out normal, so sometimes that doesn't work. And I got diagnosed with a diabetic ketoacidosis. The A1C test is the one that you do every 3 months with your doctor. Every 3 months with your doctor, and like depending on what it's at, that you get driving privileges. And I know that like to go on an LDS mission, yours has to be below 8. So there's just kind of restrictions that we have on that. Next slide, please.
I do want to insert something here because of this point that you made here, Victoria, that you have up here, a random non-fasting blood glucose level. Yesterday, I was talking about that in my lecture, and the slide is wrong. The slide said it was fasting. It is not fasting. It is a random glucose level. So you just go into the doctor with these signs and symptoms, or you're complaining that you're peeing all the time or something like that, and they'll take your lab work, and you haven't been fasting. Usually they always like to do lab work when you're fasting, but the random non-fasting one, the level for that has to be if it's 200 milligrams or higher, then you can be diagnosed with diabetes. So I just wanted to point out that Victoria's is correct. Vicky's is wrong. Okay, just keep that in mind when you're studying. Sorry for the interruption.
You're all good. Yeah, so next slide. The treatment varies by, honestly, insurance and what's more comfortable for you. I love having a pump. A lot of people are kind of freaked out by having a little cannula inside their body 24 hours, but you change it out every 3 days. And instead of poking myself every time I want to put something inside of my mouth, I just click some buttons. So I'm about that. Also, I've had better control with the pump. I usually was like in the 7 range, but like with 3 months of my pump, my A1C went down to a 5.9, which is like barely diabetic. There's the syringe and pen for people that don't want that, or it's cheaper depending on what they want. If you don't have a pump, you do need a Lantus shot at night before you go to bed. I don't know why, but that is like one of the most uncomfortable shots. It like hurts going in, even if you take it out of the fridge. So most of the times, that's how I look at my plate of food. Sometimes I kind of forget. Kim has heard me. I forgot one time to like bolus for my dinner. Sometimes I get hungry and I just start eating. But yeah, I like look at my food and look at how many carbs it is, calculate it, and then put how much I'm gonna eat, and then that gives me an insulin bolus for it. So bolus is like an amount that you're getting for eating, and basal is just like a continuous drip. The rule of 15 is that what you do when you have the low blood sugar. Correction doses is like I have to give myself 1 unit for every 55 that I'm above 150. And then we talked about A1Cs, and I just put that insulin was first developed in the 1920s. So like before people had like 3 to 5 years to live, and now they have insulin, which is great because yeah, I like living most of the times. Next slide, please. So just some lifestyle changes to reiterate. We can eat the same foods. We just have to count our carbs. And just be healthy so you don't have complications, because I don't want to cut my feet off. But yeah, that's basically it.
Well, here, let's all clap. I'm sure you hear it, whether you can or not. No, excellent thing. Remember, people, that there are questions that are on the exam right from this presentation. So don't let's see. Don't just listen to this and then negate it and not look at it again. Please review the handout. And like I said, she has a learning exercise. Okay, so the next thing that we're going to do is we are going to do Emma's foot care, maybe. Once again, it's a maybe. Let's try this. And we have nothing. So let's just see this slideshow.
It's just like,
oh,
yeah.
Can you now?
The same thing where it's like just half of it. That's
oh my gosh, I don't know what's going on.
That's fine. I'll just go off of it. I have it pulled up, and you guys can kind of follow along. But this is a fairly quick one anyways. So I'm talking about diabetic foot care. Also, I hope they're like doing maintenance outside my apartment right now. I hope they're not like loud.
We're used to it. They just we're finishing the building when we moved in. So we'll just attribute it.
Yeah, I'm just like, that's just kind of how it is. Okay, so we're going to start talking about effect of diabetes on the feet. So The higher blood sugar than normal, as well as damage to the small blood vessels, decreases the ability for them to feel injuries. And the motor nerves that control the shape of the foot are also damaged, which results in deformities of bony prominences, commonly the tips of the toes, the heels, the arch, and the ball of the foot. And then the elevated blood glucose levels impair circulation of the blood vessels that supply the skin, and the body requires 50 times the normal blood flow to heal when there is a skin injury. So if you're diabetic and the circulation is already impaired, then healing is unavailable, which causes the skin to deteriorate. And we'll go on to the next slide. So purposes of foot care. Oh, you can just see the foot on your guys' big blue button. But the purposes of foot care are to prevent ulcers, to prevent injury to the foot, promote early healing of the foot so you can get early intervention, and to maintain mobility and function, to prevent infection, and to save the foot from amputation. So on to the next slide. Oh my gosh, you guys just see that horrible picture. But so signs and symptoms of diabetic foot problems. So they can have burning and painful feet, swelling of the feet or legs, loss of sensation to cold or touch, thickening and yellowing of the toenails, which isn't always like a sign of being diabetic, but it's just something that can happen along with these other symptoms. And the biggest thing is the onset of red spots, blister sores, ulcer, infected corners, or ingrown toenails. And I just had to put that necrotic foot there because when I first was a CNA, I was working at a veteran's home down in St. George, and I had this diabetic patient, and he would not get his feet amputated, and he needed to in the worst way. And I remember my nurse saying, she's like, and his toes were just super necrotic like this. And she was like, well, when you guys transfer him, like, just look at his shoes after, because I wouldn't be surprised if one of his toes fell off in there because he had already had a few of them fall off. And being like new to healthcare and stuff, I was like, are you kidding me? But I wanted it to happen so badly while I was working. But never did, which I guess is a good thing. And kind of like, if it happened, I wanted it to be while I was there. Okay. On to the next slide, nursing interventions. Okay, so I put this little picture up because most of these foot problems are completely preventable. So it's like that saying, an ounce of prevention is worth a pound of cure. That is so true in this case. So the first and most important thing for them to do is to inspect their feet every day. And if they can't like see the back of their feet or in between their toes, they can use a mirror or ask like a family member or someone for help, just because they need to really keep a close eye on their feet, and they should contact their doctor immediately if they see any sores, redness, cuts, blisters, or bruises are noted. And they need to wash their feet every day with warm water and mild soap, but they shouldn't soak their feet because that can cause like skin breakdown over time and whatnot. But they should wash them every day. And then afterwards, they need to dry their feet really good, dry in between their toes. Infection can develop in moist areas, and moisturize their dry skin. And they shouldn't use lotion in between their toes because that can also cause moisture and skin breakdown. And toenail care. So I read quite a few different things about this, and I think it's kind of one of those things where a lot of what we're going to be doing with our patients is educating them. And so it's important to like educate them on how to take care of it themselves and what to do if they can't take care of it themselves. So you're going to want to teach proper toenail care after washing their feet when their nails are nice and soft. And they shouldn't cut into the corners. They should cut just like straight across, and use emery boards if needed. And they shouldn't cut their toenails too short. But if they are having issues with any of these things, or if their nails are thickened and yellow, then they should just go see a podiatrist and they can take care of their feet. And then they should choose comfortable and well-fitting shoes with clean, dry socks. Before they put them on in the morning, they should inspect the insides for any tears, bumps, or anything that could add pressure to their feet. And then they should avoid like thong sandals, flip-flops, pointed toe, and open toe shoes because they are at risk for injury, and they should avoid high heels. And they shouldn't buy shoes that are too tight, hoping that they will stretch out. They should buy them already with room in the toe box. And we'll go on to the next slide. And so this is kind of just like there's so much education, it's just kind of continued. But an antiseptic solution can burn the skin, so don't use it on feet without doctor approval. And then never use a heating pad, hot water bottle, electric blanket on the feet, because that can cause, since they don't feel their feet very well, they could have burns. And then they should wear socks to bed if their feet are cold. And they should avoid walking barefoot because it can cause sores or injuries that get infected. They should avoid tights since the seams on that go across the toes can add pressure. And we'll head on to the next one.
Oh, I think I did the wrong one. This one.
No, you're good.
Yeah. Okay.
A question. Okay. Oh gosh, you guys can't see it. But so for my learning activity, I just have a couple of little test questions for you guys. So in educating a client with diabetes, what response would reveal need for further education? So A, I should avoid tights. B, I should take good care of my toenails. C, I should not go more than 3 days without washing my feet. Or D, I should avoid going barefoot and should wear clean socks. So which of those would reveal need for further education? I'll wait for you guys to put in the chat. I know it's hard when you can't actually see the question. So just go ahead.
Can you see the chat?
Yeah, I can see the chat.
Okay, because I can't.
Okay, you're good. I'll tell you if they get it right or not. Okay, so most of you put C, and that is correct. The recommended self-care routine is to wash feet on a daily basis without soaking and carefully cleaning. So they were on the right track. I kind of tried to trick you guys there. Okay, and on to the next question. Oh. Not like you guys can see it anyways, but you know. Okay, so the nurse is caring for a client with long-term type 2 diabetes and is assessing the feet. Which assessment data would warrant immediate intervention by the nurse? A, the client has crumbling toenails. B, the client has athlete's foot. C, the client has a necrotic big toe. Or D, the client has thickened toenails. I shouldn't have had both of them C because I don't know where. Okay, so C is correct. So it's necrotic big toe because this indicates dead tissue. The client doesn't feel the pain in the lower extremity and doesn't realize there has been an injury, therefore doesn't seek treatment. Increased risk of developing an infection due to the decreased blood glucose levels, decreasing oxygen supply. That was a mouthful. But yeah, there's your necrotic big toe. Go have breakfast now. And thank you.
Well, thank you very much. Again, applause, applause, applause in the little chat room. Here we go. All right. All right. Again, I know there are specific questions in the test with regard to foot care. And if you will remember, in our vascular lecture, we also had, for people that have peripheral artery disease, foot care. And if you'll notice, the two are the same. So what are you likely going to do, the same kind of interventions, anytime that you have decreased circulation or perfusion to the lower extremities with regard to foot care? All right, so here we go, Jaden. Let's see if I can pull you up. I don't know. I'm going to hit this. Here we are once again talking to myself, and now it's not even wanting to share my screen. There it goes. And then I want to do the application, and then I want to do the exercise. And now, let's see. So, slideshow. I just don't understand why you're getting half. Just don't get it. All right. Jaden, are you there?
Yeah, can you hear me?
Yes.
All right. Yeah, I don't see it on your screen, Vicky, but you guys can just pull it up in the modules if you want to follow along.
There you go.
So mine is, exercise guidelines for the diabetic patient. A lot of this will be a repeat from yesterday, but it's good to hear things twice. Vicky, I would have intervened yesterday if I was ready to present yesterday. But I had not even done my PowerPoint yet. I saw you going over it, and I was like, "Ooh, was I supposed to go to that?"
I know, and I so apologize. And aren't you lucky? You're the very first, so it's just a repeat. You're doing the studying for them, so good for you. They'll probably pay more attention to you. I'm sure they will than they did to me because it was a long day yesterday.
All right, so jump into the second slide. So exercise frequency. It's recommended that you strive for 150 minutes of moderate intensity exercise each week. And so to achieve that, it's easiest if you break that up. So if you were to break that up to a daily exercise, that would be about 20 to 25 minutes a day for 7 days a week. Just because 150 minutes would be pretty daunting to do in one sitting. At least 2 days of the week, it's recommended that exercises should work all of the major muscle groups, and strive not to go longer than 2 days without exercise. And then it's also recommended to exercise at the same time each day. And like I said, it's moderate intensity exercise. So this doesn't have to be like, you don't have to go running every day or anything like that. A lot of the recommendations are just movement. Even like housework or mowing the lawn is considered exercise, moderate exercise. So jump into the next slide. Blood sugar checks. It's important to check your blood sugar before and after exercise. So if you check your blood glucose after exercise and it's lower, eat a snack to prevent hypoglycemia. If exercise is longer than 2 hours, then make sure to do a blood sugar check mid-exercise. So if you're like running a marathon or something like that, get your blood checked like halfway through. I found this interesting. This wasn't on the CDC website, but it was on a research paper I was reading, and it said that sprints and heavy lifting, so like explosive movements, can raise your blood sugar and cause hyperglycemia for diabetic. And then it's also really important to check your blood glucose before exercise, just looking for hypo or hyperglycemia. If your blood sugar is below 100 milligrams per deciliter, eat a small snack before you go exercise so your blood sugar doesn't tank. And then also, if your blood sugar is too high, if it's hyperglycemic, exercise is not safe until your glucose drops. And then it also recommended on the CDC website that if your blood sugar is high, like above 240, also test your urine for ketones. All right, next slide. So just kind of echoing what Emma just talked about, safety. Wear appropriate protective equipment to prevent injury, specifically shoes. Wear well-fitted socks and shoes. And then after each exercise, check for foot injuries, including like blisters or cuts after workouts. And if those foot injuries have not healed within 2 days, then you need to contact your healthcare provider. All right, so here are some examples of moderate exercise. You can get creative with it. So we got dancing, gardening, mowing the lawn, swimming, bike riding, rock climbing, weightlifting, sports, a brisk walk, housework. So there's a lot of different things you can do to get a moderate exercise. Something that I've kind of done during nursing school, I know it's hard because we're pressed on time, is I like to cycle. I like to ride my bike, and a lot of times I'll plug in instead of just studying at a computer, I'll listen to a lecture while I go for a bike ride, just to kind of mix it in, break up the studying. But yeah, there's a lot of things that we can do to exercise. And then here's just some tips for getting started. Do something you already enjoy. Like running, for example. A lot of people are like, oh, I hate exercising, I hate running. Then don't run. Find something else that you enjoy doing. Start out small and slowly build. A lot of times people try and jump all in and they exercise super hard and don't enjoy it. But if you start out with small exercises, a lot of times you'll slowly build and begin to enjoy it more. Schedule exercise in your day and make it a priority. And it takes time to get into, like I've already said, into a routine and really enjoy it. So be patient. And then set a SMART goal. That is a helpful tip. So sign up for a race or a competition. Make the time frame short, not too far into the future. And then jumping up to my last slide, which is just the learning activity. So you don't have to do this right this minute, but take a few minutes today and set a SMART fitness goal to start now until the end of the year, just to get moderate exercise each week. And that is everything.
Hey, applaud, and go for it. You guys go for that exercise till the end of the year. It could have been till the end of the semester or the end of the week. Oh my gosh. All right, let's go. Good job though, people. Again, I can think of specific questions on the test that come directly from this PowerPoint. So pay attention to your fellow students. All right. No, cancel. No. There we go. All right. So I hate to get started in this new category or group of slides because it doesn't talk about diabetes. Diabetes, of course, is the #1 endocrine issue. One thing that I was really impressed with Victoria's presentation was she was talking specifically about type 1, but did you see those figures? 16 billion dollars that were spent on type 1 diabetics in the United States. And remember, type 1 only accounts for 5% of the people that have diabetes, the other 95%, of course, being type 2 diabetes. But the cost is astronomical. And you can understand, too, think about this, and something that I didn't mention yesterday was the federal government, Medicare, Medicaid used to pay for diabetic supplies for people that qualified. Well, guess what? Funds are being cut, and they are not supplying 100% of that anymore. They have cut significantly the reimbursement or the payout to people that qualify in the amount that they get for their supplies. And so if somebody doesn't have the money, extra discretionary money for their medications, then guess what? They're not going to be compliant with their schedule. And instead of taking their blood sugar checks as prescribed before every meal, did I say blood pressure? I'm losing it. So no, they're taking their blood sugar checks right before their meals. They're going to skip maybe lunch, maybe they'll skip breakfast, doing it then, and they won't take their insulin because they don't know exactly how much to take, and so they cut the number of times and the frequency that they're testing their blood sugar, and so are also cutting the cost, cutting the amount of insulin they take, and insulin has skyrocketed. And so there's been big debates in Congress about overpricing and that type of thing. And so it's it's a huge, huge problem. But with 95% of the people that have type 2 diabetes, a large number of that, the majority of those people, could control that type 2 diabetes, and it could even go into remission if they manage their nutritional intake. Did you have something to say, Emma? Or are you just playing with your button there? Just play it. All right, let's take a 10-minute break here. Let's come back at 5 to 9, and we will start this titillating lecture on the other endocrine problems. I mean, you didn't say your name. You just said, "Hey, Vicki." I knew exactly what I needed to do. Thank you. But with tertiary hypothyroidism, what the problem is in the hypothalamus, and that can be due to an injury, motor vehicle accident, maybe a stroke, but that thyroid releasing hormone is not being produced, and therefore thyroid stimulating hormone is not being produced, and therefore T3, T4 hormones are not being produced. So again, this goes back. We went in one direction to talk about what stimulates it, and then primary begins in the thyroid, secondary begins in the pituitary gland, and tertiary begins in the hypothalamus. All right, so let's look at some of the clinical manifestations of hypothyroidism. The patient is going to struggle with weight gain because they just cannot burn enough calories. The metabolism is such that they just can't burn sufficient. And no matter, if they lower their dietary intake of calories, it doesn't matter. They just struggle with losing weight. They're not able to tolerate cold temperatures because they can't regulate that body temperature. And the patient may exhibit a goiter at the base of the neck because of the negative feedback loop not working. So the thyroid stimulating hormone is being overproduced. So with primary hypothyroidism, remember, it's the thyroid itself that is not releasing the hormones. So the negative feedback loop to the thyroid, to the pituitary gland is, hey, there's no thyroid, there's no T3, T4 in the system, let's get on it. So thyroid stimulating hormone is going to increase its production. The pituitary gland is going to increase its production of thyroid stimulating hormone, which will then stimulate the thyroid to work harder to produce T3 and T4. But again, there's some deficit there that the thyroid is not producing, but it's working harder to produce it. And that's basically what a goiter is. And that's found at the base of the neck. Okay, so cardiovascular wise, it's going to be bradycardia. So when you think of hypo, you're thinking slow, you're thinking low. So cardiovascular system, there's going to be bradycardic, there's going to be decreased cardiac output, which means what? Low blood pressure. There's going to be cool skin, and there will be an intolerance to cold, again, because of the inability of the thyroid's T3 hormone. There's insufficient there to help regulate body temperature. With neurological system, there's going to be apathy. The person's going to be lethargic. There's going to be slowed movements. There's going to be memory loss. Do you think I have hypothyroidism? I just thought of that. Maybe I do. Struggle with weight loss, fatigue. I have no goiter though. Anyway, all right. So with pulmonary or with the respiratory system, there's going to be dyspnea. There's going to be hypoventilation, With the integument system, there'll be cool, dry skin because of decreased sweating. And there'll be thinning and brittle, dry hair. Now, that will be something if you're doing an assessment specific to hypothyroidism. Then you see their hair, you're examining their hair, and you note that it's very thin and very brittle. That's going to differentiate it from hyperthyroidism in just a minute. So these are two specific clues here that you want to look at. Gastrointestinal, they're going to have decreased appetite but increased weight. And they're going to have constipation because of decreased peristalsis. They're going to have hyperlipidemia, and of course, with constipation, they're going to have decreased defecation. So with the skeletal system, a low metabolism is going to cause an increase in bone density, but it's going to be very poor quality, and the person will be at risk for having a fracture. And then reproductive system, there's going to be a decreased libido, there will be a erectile dysfunction, and amenorrhea. So what are we going to do about this? I mean, you know, we're talking about the inside of the body. We're talking about the release of hormones here. So there's not anything we can do to cure this. It's not like we can have them turn, cough, and deep breathe every 2 hours to prevent further episodes of hypothyroidism. But we have to recognize as nurses what the complications are because of the things they may be experiencing, what T3 is responsible for. So you realize they have a cold intolerance, so let's keep them warm. Give them a couple blankets or two, or crank up the temperature in the room. You want to monitor their weight because, again, they are struggling to have enough metabolism to process those calories that are ingested. We want to monitor their vital signs and their glucose levels. Activity intolerance, they're going to be very lethargic. Does that mean we keep them on bed rest? No, that's right. You don't keep them on bed rest. They have activity intolerance. They're going to be fatigued. So they're not going to get up probably by themselves. They probably won't initiate ambulation. So we need to get them up and walking around the nurse's station at least 3 times a day, even though they have activity tolerance, but we want to, of course, put them at fall risk and make sure that they have assistance when they are ambulating. There's a risk for impaired skin integrity and, of course, imbalanced nutrition because they're trying to lose weight, but they can't. So what do you do when you have somebody that has hypothyroidism? So with hypothyroidism, that means we don't have enough T3. So what do we need? We need to take some synthetic T3, synthetic hormone replacement. So the most popular that we have is levothyroxine. Levothyroxine. So that is the most common. This is something that you need to know about this, and that is that, first of all, if it's a synthetic hormone replacement, okay, so the body's not producing its own, then we're going, it's not, you just don't have enough T3. So we're going to supplement it with some synthetic T3. So the thing about this is that it comes in very low doses. We're talking like mics, so 5 micrograms usually. However, sometimes there will be cytomel, which is for people that have been on chemotherapy or something and the thyroid has been effective. It's natural for as a person ages, and you learn this in human anatomy, that as a person ages, the thyroid stops making, or starts, it doesn't stop making, but it starts decreasing the amount of T3 that it produces. So there are many geriatric patients that are on levothyroxine. And the thing about that is that it has to be taken by itself, at least an hour before you do anything else, before you take other medications, before you eat any food. It has to be taken by itself. And some nurses don't know that, or haven't read that, or whatever. And so they give it with the rest of the morning med pass, and then anything that is given in the GI tract, or for the GI tract, or for other medications as well, can inhibit the mechanism of action for the levothyroxine, and so it doesn't work at all. So you have to be very careful of that. Now, I told you with the synthetic hormone here that 5 mics is a common dosage for that. But for people that have had chemotherapy or had their thyroid removed, you'll see that they have 5 milligrams. So you better check the dosing on this, and this certainly doesn't replace this. So you have to be very, very careful of what you're giving and the dosing on that. Also, there's a thyrolar, which increases the sensitivity to sedatives and opioids, so you have to be very careful in your medical management. And again, don't you think this would be important to know before you give it and after you've already given some morphine? Yeah, it is true. Now, it's real important that you educate the patients not to stop their medications abruptly, because it can result in the person going into crisis. And speaking of crisis, then one of the complications of hypothyroidism is myxedema coma. And this is where the metabolic rate has dropped so low that it becomes life-threatening. So it's usually the result of uncontrolled hypothyroidism or a thyroidectomy. They've cut the thyroid out because of nodules, or because of cancer, or because the goiter had encroached upon the gland too much, or something like that. So we have to be aware of that. And I think that we're going to talk about a thyroid storm here in a minute, which is for hyperthyroidism. But for this type of complication, look at this coma. So it's going to be hypo. This is low. Coma means you're about as low as you can get as far as neurological function is concerned. So you realize everything's going to be slow. Extreme drowsiness, respiratory failure, bradycardia, hypoglycemia, hyponatremia. So again, myxedema coma, usually the result of stopping the medication abruptly or having a thyroidectomy. All right, so this is what we have to educate our patients about. We've already talked about the medication. Take the medication in the morning without any food, and don't take within 4 hours of taking GI medications. So don't take Carafate, aluminum hydroxide, or Gas-X. This is the one that we wait 4 hours for. If you took this in the morning and knew that breakfast is coming, you may want to reschedule these for in the afternoon so that the Synthroid medication will have plenty of time to work. The signs and symptoms of toxicity are going to be the exact opposite for hypothyroidism. So you've taken too much medication, you're going to have an increased heart rate, you're going to have chest pain, heat intolerance, so exactly the opposite. and notify the HCP immediately if any of those symptoms appear. Okay, so let's go to the other end of the spectrum now, so that we have hyperthyroidism, where too much T3 is being produced. It causes, it's usually the biggest number one cause for this. Oh, let me go back to this because I didn't mention this in the slide and it's not there. But the number one cause for hypothyroidism in the United States is Hashimoto's disease. Now, Hashimoto's is a endocrine disorder. It's an autoimmune disorder. And so we don't really know what triggers it. We don't know if it's a stressful event. We don't know anything. It's first determined by finding this little nodule at the base of the neck, which just happens to be a little goiter that is starting to develop. We talked about the reasons why goiters can develop. But it's Hashimoto's, an autoimmune disease that, of course, results in hypothyroidism. So now we're going to hyperthyroidism. And the number one reason in the United States for hyperthyroidism is Graves' disease. And Graves' disease, did you know Barbara Bush had Graves' disease? Yes, she did. Do you guys even know who Barbara Bush was? You're too young? I don't know. Anyway, it can also be caused by toxic nodular goiters, which are little tiny goiters that grow on the thyroid gland. It can be from inflammation of the thyroid, so thyroiditis. It can be from patients taking too much Synthroid. So they think they want to lose weight, and so instead of taking their 5 mics of T3 every day, or the synthetic hormone, they want to lose weight, so they take 2 or 3 of those little pills. Yeah, it can cause hyperthyroidism, all right. It can be heredity, and it can be from too much ingestion of iodine. So the secondary cause for that can be that the pituitary gland causes excessive thyroid stimulating hormone to be released. And then the tertiary, of course, would be the hypothalamus, which produces excessive amounts of thyroid releasing hormone. So what are the clinical manifestations of hyperthyroidism? We'll begin that it puts a person into a hypermetabolic state. So again, the mechanisms are working so fast that you're not trying to lose weight, but you lose weight. And you cannot tolerate heat because everything is working so fast in your body. And so we notice that they cannot regulate their body temperature. And then it may be that they have a goiter as well. Cardiovascular-wise, they're going to be tachypnic, they're going to have palpitations, they're going to have increased cardiac output, which means what? Hypertension. They are going to be very warm, and so you're going to need to crank down that room thermostat. Neurologically, they're going to be fatigued because everything is moving so fast. There's just not enough energy there to sustain those metabolic processes. And so that's why you're going to have fatigue. They're overworked. The metabolic processes are overworked. There'll be hyperactive reflexes. There may be tremors. A person can't sleep, so it's insomnia. And of course, they may have some emotional instability because they're just very irritable. They're very short-tempered because they just are in hyperactive mode all the time. Pulmonary, they're going to have some dyspnea. Integument-wise, they'll have diaphoresis. They'll be warm, moist skin, But here is a differentiation that you can make, is that they have very fine, soft hair. And then gastrointestinal wise, they'll have an increased appetite, yet a weight loss. They'll have diarrhea. Diarrhea is fast peristalsis, decreased lipids. And then with a skeletal system, they'll have reduced bone density and an increased fracture risk. And then reproductively, there will again be a decreased libido, erectile dysfunction, and amenorrhea. So what are the interventions that we're going to do for hyperthyroidism? Now with hypothyroidism, remember we're going to do hormone replacement. But with hyperthyroidism, we're going to have anti-thyroid medications. So there's different mechanisms of action to make that happen. And you will talk about that in pharm. So I will tell you, don't worry about this, because why? You can worry about it in pharm. We don't want you worrying about it in two places. Just worry about it in one. So, but another treatment that we can do is give the patient radioactive iodine, because that is going to destroy the thyroid gland over time. And it's permanent. They don't go, it doesn't come back after a while. It's permanent. So, of course, with radioactive iodine, it's contraindicated for pregnant women or who are breastfeeding. It can cause iodism, which is a metallic taste in the mouth, and very swollen saliva glands. And it may result in the patient being required to have a surgical thyroidectomy, because the body always being at a high level like that of metabolic processing cannot give the body time to rest and heal. And so if we have too high of hyperthyroidism, then we may need to do a thyroidectomy. Now, the thing about a thyroidectomy is, remember what the guidelines were with hypothyroidism, and the medications don't stop the medications abruptly. Well, the same happens here with with hyperthyroidism, is that we don't want to just take out the thyroid and have the whole body going at high speed and then boom, nothing. So what we'll do is we'll give them these anti-hyperthyroid or anti-thyroid medications prior to surgery and get it to slow down and slow down and slow down. And then so that it won't be such a shock to the system. Oral iodine can reduce the vascularity of the thyroid gland, so may cause to shrink it if that is a potential medical intervention that the doctor may want to try. So when a person has had a thyroidectomy, remember back in the day that what we want to do is always assess airway, breathing, and circulation. If there is surgery around the neck, go back to your, when we did the musculoskeletal surgeries, go back and look at that. But we assess for airway, breathing, and circulation. We check for bleeding and drainage at the incision site, and where we're going to check dependently as well. Check for the swallowing ability, monitor vital signs of neurological status, monitor for hoarseness, monitor for respiratory distress. Keep the patient in semi-Fowler's position, so any swelling will, the gravity will help potentiate the drainage away from the neck. And when the patient needs to cough, have the patient split the wound up here so we don't dehiss. So what are the interventions we're going to do with hyperthyroidism? As we've talked about already, keep the patient comfortable, keep the patient cool and quiet, administer sedatives if necessary, obtain weight, monitor heart rate, blood pressure, and as ECG, educate the patient about medications and treatment, and monitor for thyroid storm. So We learned earlier about myxedematoma as being a complication of hypothyroidism, but hyperthyroidism is going to be a thyroid storm, and that should give you an indication of which is which. The storm indicates high activity. So this is when the metabolic rate is so extremely high that it becomes life-threatening. And this can result because the patient has had a thyroidectomy or they've had uncontrolled hyperthyroidism. So their symptoms are going to be hyperthermia. So they're going to have a very high fever. They're going to have hypertension, tachycardia, restlessness, delirium. Their treatments are going to be acetaminophen, IV fluids, cooling blanket, beta blocker, oxygen, and increasing the bed to 30 degrees. And we want to do this, and we need to recognize it, again, because it can be life-threatening. Of course, the physician needs to be notified. So what are we going to educate our patients on who have hyperthyroidism and had a and have had a thyroidectomy? We want to educate them again, just like the hypothyroidism, to stop taking their medications abruptly. That we want them to take their medication at the same time every day. We want to educate the patients on signs and symptoms of a thyroid storm so they can monitor themselves when they go home. We want to educate the patient to avoid foods rich in iodine and educate the patient to avoid aspirin because it increases the production of thyroid hormones, which I think is very interesting. Educate the patient to watch for toxicity symptoms and such as hypothyroidism, bradycardia, fatigue, and hypothermia. So again, whenever we're talking about toxicity, you look for the opposite effects happening to the person than what they normally experience. So, what do you think? Why are we monitoring blood glucose? Because if you have hypersecretions of all the metabolic processes in the body, what is it also going to secrete? Other hormones such as corticosteroids. We just want to be looking at that all the time, all the time, all the time, all the time. Okay, here's one for you, pheochromocytoma. I think I said pylo yesterday, but it's pheo. Pheochromocytoma is a little tumor that is found in the adrenal gland. So the adrenal glands are found at the very top of the kidneys, on this little thing that sits on top of the kidney called the adrenal gland. And if we were to cross-section the adrenal gland, you're going to find that there's the outside capsule to it, but then there's a couple of layers inside. And we have the cortex, which is the outermost layer of the adrenal gland. And then we have the medulla, which is on the inside. So the pheochromocytoma is going to be found right there in, let me see if I can point it to you. Let's go back. Okay, it's found right here in the cortex. Okay, the outside. Now we're going to talk about something else that's found on the inside later, but we're going to talk about this right now. So pheochromocytoma is found in the cortex. Figure out how you're going to remember that. All right, because again, we're going to learn about another disease that is found, or another type of tumor that is found in the medulla of the adrenal gland. You're going to need to be able to differentiate which is which. So the pheochromocytoma tumors, I think I just told you that wrong. middle layer of the kidney is the adrenal medulla. And oh, you're right. I'm right. I'm wrong. It's found in the medulla. I'm sorry. It's found in the medulla. See, how many of these have I seen? None. I haven't seen either one of those. So the pheochromocytoma is found in the medulla in the middle. Here. Is somebody talking? Does somebody need me? No, it's not very interested. It isn't. Okay. So what is dangerous, let me just say that, about the pheochromocytoma is that that they are in the medulla. There are certain cells that secrete the epinephrine and norepinephrine and a small amount of dopamine in response to the body's sympathetic nervous system. So if there's a tumor there, then there's going to be excessive amounts of epinephrine and norepinephrine being released into the bloodstream. So what do you think that's going to do to the person? Yeah, send them up over the edge, don't you think? What are some of the responses of the sympathetic fight or flight? Exactly, which means what? Everything is elevated. So now you have a tumor in here and you have super elevation. You know, another word for epinephrine is adrenaline. So you're sitting there and you have this hyper secretion of adrenaline. So everything in the body's going to go wonky. So you can see that this can be a very dangerous type of tumor to have. And where is it found? Yeah, in the medulla. Let's remember that. Okay, I can't from lecture to lecture. Is it the cortex or is it the medulla? It's the medulla. So again, you're going to have exaggerated fight or flight symptoms. So look at this hypertension off the wall. Tachycardia greater than 100%, palpitations, tremors, diaphoresis, feelings of apprehension, severe pounding headache. It is bad news bear. It is a bad news bear, especially this hypertension. Oh my gosh, put you right into the grave. So the therapeutic interventions that we have to do is first we've got to diagnose this. And let me get over here to my slide that I got to look at. All right. So what happens is that patient, of course, doesn't know they have it, but all of a sudden they're going to present to the ER with a really, really high blood pressure. And so what the provider may order, of course, they don't go in and immediately cut it out. They've got to diagnose it first. So what the healthcare provider is going to do is order a 24-hour urine test. And what we're looking for is VMA, which is basically it just, trust me, it's just VMA. I can't even pronounce them. So, but they are the end products of catecholamine metabolisms. So if the results of the test are elevated, then a CAT scan will be ordered, an MRI may be ordered to locate the tumor and see what's causing those high levels of VMA, which are the result of catecholamine metabolism. So the treatment's going to be surgical removal of the pheochromocytoma. The thing about the pheochromocytoma, remember how many kidneys do you have? 2. Thanks, I'll answer it for you. And how many adrenal glands are we going to have on top of those kidneys? 2. So the pheochromocytoma may be in one kidney, or it may be in both. And so what they will take off is the adrenal gland, not the kidney, just the adrenal gland. However, now we've got a problem, because if we take off 2 adrenal glands, then there's not going to be the production of epinephrine and norepinephrine. So it has its problems. So again, we need to examine the potential consequences that is going to be the result of the taking the gland off if it's 1 or 2. If it's 1, there's really no really adverse effects because your second one is making the epinephrine and the norepinephrine. But if it's bilateral removal of the adrenal gland, then there's going to be problems. So, preoperatively, I'm sorry, the patient should be in what they call a euthyroid state. And this means that they have, you want them to be in as level as possible. We don't want them to be in crisis during the surgery. So what can happen is that they may be ordered an alpha adrenergic blocker. I'm trying to get my mouse over here to work so I can get on the right side. An alpha adrenergic blocker to deal with blood pressure issues before the surgery. Again, we've got to have them as close to being normal as they possibly can. And they should get, of course, a baseline assessment of their vital signs and that type of thing. Post-operatively, we want to monitor for vital signs and oxygen saturations. We want to monitor their blood pressure, of course. And we want to make sure that we do all the other kind of things that are necessary after a post-op with a post-surgical patient. So, first of all, we want them to be on a high-calorie diet. We don't want them to have any caffeine or energy drinks. No smoking cessation. No smoking cessation. Just no smoking. Cessate smoking. Is that really a word? I don't know. And then we want to put them on hormone replacement therapy. And again, if this is bilateral, then that therapy is going to be for life because they're not producing any of the epinephrine and norepinephrine that is needed in stressful situations. So also, they may be ordered some glucocorticosteroids or some mineral corticosteroids, okay? Because the adrenal gland is also responsible for producing those hormones. Okay, so pheochromocytoma was part of the medulla. And again, this is kind of an opposite. When you're studying these, study these in pairs because you want hypothyroidism and you want pheochromocytoma and you want Cushing's syndrome. So we know that pheochromocytoma is part of the medulla, and if you have a tumor in there, you're going to have excessive norepinephrine and epinephrine produced. But with Cushing's syndrome and C. Cushing's and C. cortex, there's going to be a tumor found in the cortex of the adrenal gland. And so there may be excessive corticosteroids and mineral co-steroids that are being produced. So the clinical manifestations, let me go back here for just a minute because I do want to spend some time on some of the pathophysiology of this for just a minute. So some of the hormones that are produced in the cortex of the adrenal gland is aldosterone, and aldosterone helps to regulate blood pressure through the renin-angiotensin-aldosterone system. It will retain sodium, it secretes potassium, anything that affects the secretion of aldosterone will also affect sodium and potassium levels in the body. So is that going to be important? Yes, that's very important. It is an important little tumor here. So with the function of cortisol, it also produces cortisol. So these are your stress hormones, and they help the body deal with stress, both internally and externally. And it increases blood glucose by breaking down sugar intake and breaks down fats, proteins, and carbohydrates. And it also helps to regulate electrolytes. So the thing about it is that you have aldosterone and cortisol here. The aldosterone is the mineral corticosteroid, and the cortisol is going to be your glucocorticosteroid that is being released from there. I just wanted to make sure that you understood that aldosterone was mineral corticosteroids and cortisol was glucocorticosteroids. All right. So what are the manifestations that we're going to see for somebody that has Cushing's syndrome? Most of the signs and symptoms of Cushing's syndrome are related to excess cortisol levels. So you're going to have weight gain. You're going to have central obesity. This is where you have a real heavy set or a very large middle section to the torso, but the arms and the legs may be of normal size. They may have a fat pad or what some call a buffalo hump around the base of the neck. And they'll have a very puffy, round, very round, moon-shaped face. They may also exhibit some muscle wasting. And the thing about the Cushing syndromes that differentiates it, I told you that they're going to have a very round midsection here. And so if it comes on pretty quickly, then they're going to have striae or stretch marks. But what differentiates this from normal weight gain is that this striae is a deep purple. It's almost a classic sign. And we've got a picture of this over here. Here we go. So you see here, there's these deep purple striae here to this large abdomen. This is a classic sign of Cushing's syndrome. Look at this round moon face here. These are all very classic signs of somebody and it's the same thing for somebody that's been on prednisone for long periods of time. They've got corticosteroids. They have cortisol, excessive amounts of cortisol in their body. This is the buffalo hump or the fat pad that we were talking about as well. This is different than kyphosis. Kyphosis is located lower in the spinal area than this buffalo hump. This buffalo hump sits pretty much at the very base of the neck here. So medical interventions, what are we going to do for medical interventions? We are going to do diagnostic tests. We may need to do surgery again to remove the adrenal gland. And again, if it's one adrenal gland, we're good to go. But if it's bilateral adrenal glands, then we're going to have problems. We are going to have problems again. So there's different medications that you're going to learn about in pharm. So we're not going to worry too much about those. So what is your patient education going to be for somebody with Cushing's syndrome? We need to monitor their sugar levels, again, because of the amount of cortisol that is being released into the body is going to cause the blood sugars or the glucose levels to be very high. You want to monitor for potassium levels and sodium levels because they're going to be very decreased. We're going to monitor for signs and symptoms of fluid overload. Now, this is also going to be evident in a high blood pressure. And then monitor for infections and skin breakdown. Because why? Because it's high sugar levels are going to affect the healing time for those lesions, and then monitor patients' acceptance level of their change of appearance, because it really is devastating to them when they see how round their little faces become. So we're going to take a break here before we start with Addison's disease. So let us take, let's see, it's 10 to 10. Let's come back at 10. All right, people, let's take this home. Let's take this home. Okay, so one of these things that I wanted to clarify with what I said with the last couple of slides was that when you're studying for this part of the exam, there's going to be 45 questions on diabetes and then 15 questions about these last few endocrine disorders. So you're going to have hypothyroidism, hyperthyroidism, boom, out of the way there. So now we're going to talk about the adrenal gland. I didn't explain this well, and so I'm going to attempt to do so now. Pheochromocytoma is part of the medulla tumor of the adrenal gland, but now the cortex part of the adrenal gland has Cushing's syndrome, which we just talked about, but it also has Addison's. Cushing's syndrome is a hyper secretion of aldosterone and cortisol. And then with Addison's disease, you are going to have a hypofunction or a hyposecretion of cortisol and aldosterone. So this, be sure you pair these up correctly. Again, hypothyroidism. And then when we move to the adrenal glands, we're talking about pheochromocytoma as being part of the medulla with a super increase of epinephrine and norepinephrine. And then with the cortex of the adrenal gland, you're going to have opposites of Cushing's syndrome and Addison's. I hope that clarifies. All right, so we talked about Cushing's syndrome already, and again, everything is lowered. So you saw weight increase, you saw the round face, that type of thing. But now with Addison's disease, we are going to have insufficient production of the hormones of the adrenal cortex. So this is pretty much thought to be an autoimmune disease. In which the gland destroys the adrenal cortex in response to certain conditions such as TB, sometimes it's fungal infections, sometimes AIDS, sometimes it's metastatic cancer, whatever the cause is. Then the immune system starts attacking those little cells of the adrenal cortex, and Addison's can develop. So when we're talking about clinical manifestations, we're talking about large amounts of sodium and water that are going to result in fluid volume deficit. And it's going to be caused by profound, and that in return causes profound hypotension. And of course, with a fluid volume deficit, you're going to have dehydration. So when you have dehydration, you're going to have tachycardia. So when you're thinking about the questions and the stem of the questions and the scenarios that are given, think back through what is happening in the body. So potassium retention can cause cardiac dysrhythmias, and hyperglycemia may be severe. Coma and death can result. Hypoglycemia, weakness, fatigues, weight loss, confusion, and psychosis can develop because of the low cortisol levels. Gotta have cortisol. Yeah, you do. All right. So let's look at some therapeutic measures. I did want to stress here too on this one that there is going to be this increased pigmentation or hyperpigmentation of the skin. So they'll have these little darker spots like cafe spots, the hallmark sign. Anyway, All right, so what is going to happen here is we're going to have hormone replacement therapy. This is where we replace the glucocorticoids, prednisone, and hydrocortisone, and the mineral corticosteroids. So sometimes some androgen. Androgen is a third hormone. It has to do with the sex and reproduction, and we're not going to really deal with androgen right now, although you'll see that there are some signs and symptoms related to that. But mainly we're talking about the glucocorticoids and the mineral corticoids. So the thing about it is that when you've had the adrenal gland removed and you're not producing these hormones anymore, then you're going to have them have to take them daily for life. But the thing is, think about what the glucocorticoids and the mineral corticoids do. You can't give them all at once. You know, your body is using up energy throughout the day. So you got to give a little bit in the morning, and you got a little bit at the evening to replenish the body's resources on that. So the doctor may even during times of stress say, okay, let's double the dose on that for a couple of days. But recognize too that these are injections and that can be given if the oral route isn't available. So you have to sit there and recognize that you got to take these whether you want to or not. And if the oral route isn't available, then you got to be injected with it. Okay, the aldosterone replacement is Florinef. And again, you're going to be discussing that in pharm, so I'm not going to worry about that. So nursing interventions for Addison's disease. So monitor the vital signs very, very closely and report the fluid volume deficit to the healthcare provider. Notify the healthcare provider too if the person is going through increased stress, such as being really, really sick or other stressors that may be happening to them. Again, never abruptly stop the medication. Always wear a medication alert bracelet. And diet high in protein, carbohydrates, and salt. Yes, indeed. Why? Because we've got this fluid volume deficit here. We want the body to start retaining as much fluid as possible. So, yeah, bring out those French fries. And then avoid stress, illness, and strenuous exercise. Okay, so just like having myxedema coma or having a thyroid storm, you're going to be in crisis mode. And so it can happen with Addison's disease as well, where there's an Addisonian crisis. So if the patient is under too much stress or has some kind of illness or trauma that they're going through, there's going to be sudden pain, really low blood pressure, and it should be very, well, look at this, 3 in a row, really low blood pressure. Low blood pressure is a classic sign of shock. And so, you know, they're going to be in sudden pain, super low blood pressure, and they may have diarrhea, vomiting, and headache. And that's it. I keep punching. I thought there was more, but there's not. Okay. That's it, people. We're out early today. I know this is not your favorite lecture, and it's definitely not mine. It's boring, but still you got to know this stuff. You got to be able to recognize what Addison's disease is, Cushing disease is, hypothyroidism, and pheochromocytoma. So any questions? If you're still alive, it wouldn't surprise me if you died an hour and a half ago, but just let me know. Any questions? Fine. Then we're going to call it a day and wish you well. All right, thanks. Bye.